Thanks everyone for joining. We have an excellent crowd of people attending, and I really want to thank Dr. Slade and Baden for leading today's discussion on other causes of incontinence in female dogs. Really excited for this. Just a few housekeeping reminders. Please try to keep your microphone muted throughout the course of the discussion unless you have a question. We do always encourage these to be active discussions rather than a lecture. So if you do have a question, feel free to unmute your microphone and to chime in. You can also write throughout the chat, and we'll make sure to keep monitoring that as well too. But we always want this to be a discussion and not just we're sitting here listening to a lecture, but we're actually talking about how we practice and what we do, and I always walk away learning a bunch, and it's fantastic. So really looking forward to this, and I will turn it over to you folks. Thanks so much again for agreeing to present today.
Thank you, JD. So I'm going to start mostly by introducing Tanner, who is one of our third-year residents, and he has an interest in urinary interventional procedures, all interventional medicine. And so he has worked with us a lot over the last several years on our urinary procedures. And what we have, all of the people here who do urinary procedures have started to recognize is these very unusual appearing vestibules. And we started trying to make the anatomy a little bit more normal and feel that these animals then get a little bit better control of their continence. So we were discussing this, and Tanner's done a great job of pulling pretty much all the literature with things I didn't know that were even out there on this subject or related to this subject. And so with that, I introduce you to Tanner.
Thanks, Dr. Baden. My name is Tanner Slead. I'm one of the third-year medicine residents, and just going to be going through all of those other weird anatomic changes and dynamic changes that we think we've been seeing recently. And so let's see if I can get it going. There we go. So the way we're going to do it today is actually kind of break up the different components of the lower urinary tract and urogenital systems. And for each of those components, we will talk about some case examples. And then for the kind of primary journal article that we'll review today is this endoscopic guided laser ablation of vestibulovaginal septal remnants in dogs, just with the idea that there's a lot that we can do through our scopes to address some of these changes. And so with that, we'll get into it. And so it's kind of starting with what we address or what we find immediately upon cystoscopy, of course, is the vestibule in the vagina. And there are a number of papers out there that kind of further describe both the presence and the treatment of things like vaginal stenosis and vaginal septa. I don't think this is an exhaustive list, but I think it's most of them. But I did want to focus on these two papers specifically just to start. And so this first one being the influence of vestibulovaginal stenosis, pelvic bladder, and recessed vulva on response to treatment for clinical signs of lower urinary tract disease. And so the objective of this study was to evaluate the response to treatment in dogs with clinical signs of lower urinary tract disease and compare a group that had recessed vulvas and then those that didn't with similar signs. And so these two groups, again, one group was clinical signs of lower urinary tract disease that had a vulvoplasty and contrast urinary imaging in addition to the a recessed vulva, and then group 2 was more normal vulvar anatomy, no vulvoplasty, but lower urinary tract signs. And I like this paper, and I kind of bring it to discussion because they almost immediately bring about this idea of pooling of urine within the vagina cranial to the urethral orifice, which may or may not interfere with normal vaginal function and may lead to vaginitis and or predispose dogs to UTIs. And so in this study of the dogs with vulvoplasty performed, only one of the 5 dogs with severe stenosis responded to surgery. And the dogs that have both vulvoplasty and vaginoplasty, a larger majority of the dogs with severe stenosis also failed to respond. And then a similar outcome in the non-surgical group, so those that didn't have recessed vulvas, those dogs did not respond to medical therapy, or the dogs with more severe stenosis did not respond. And so the note that we wanted to make here, and this is something that Dr. Vaden has brought up a couple of times, is this idea that really the diagnosis of vaginal stenosis is typically made off of lateral measurements of this contrast study. And so they take the largest width of the vaginal vault and compare it to the vaginal opening and come up with these ratios. And as you can see here is kind of where they denote severe, moderate versus mild, and that's where they ended up doing their stats from. But our question is, could the stenosis in some of these cases, especially those that didn't respond, actually have been due to some sort of vaginal septal remnants, because we know that those can narrow the vaginal opening, especially again in those cases that were severe and didn't respond, because there's not a whole lot of mention of complete vaginal examinations in this study. And really, we're not seeing vaginal stenosis regularly, at least at NCSU. And so this is where I wanted to do the first poll, JB. So or JD, excuse me, is vestibulovaginal stenosis a differential that's often worked out via contrast study at everyone else's hospital?
We'll let it go for a few more seconds if you want to go ahead and make your vote. All right, I'm gonna go ahead and close it in 3 seconds. Last chance to get your voice counted. Okay, we'll close that. I don't know. Does it show the results, or it might not? Is it just blank for you guys?
It's just blank for me.
Okay, so the results are 54% said no, 35% said no but considered in refractory cases, and only 11% said yes.
Okay, great. And so that's kind of consistent again with what we do here at NC State, not only because we don't do those contrast studies to look for it that often, but we're really not seeing it. And again, we think that this could be due to other more common vestibulovaginal abnormalities. And that's where I wanted to talk about this paper, so endoscopic guided laser ablation of vestibulovaginal septal remnants in dogs. And so this paper, the objective, of course, was really just to describe the technique and then outcomes. But I do think it brings about some good points. And so the first one's being in the discussion, which just kind of starts with reviewing the embryology. And so this idea that the paramesonephric or Müllerian ducts ultimately fuse to become the uterus, uterine tubes, and cervix and vagina, whereas the urogenital sinus becomes the vestibule, the urethra, and the urinary bladder. And it's fusion of these two things that ultimately create the vaginal opening. And so if that doesn't happen perfectly, or they fail to fuse, then that's when we see things like imperforant hymens, stenosis, hypoplasia, apoplasia, and then these persistent remnants. And then what I thought was really helpful is their more definitive differentiation between some of these types of remnants. So the PPMR is one that they define as excessive tissue that extends less than 1 centimeter cranially, but it can't be digitally perforated. A vaginal septum, in contrast to that, extends greater than 1 centimeter, but doesn't go all the way to the cervix. And then the dual vaginas actually extend all the way to the cervix, so completely splitting the vagina into 2 compartments. And so these are their examples, at least in this paper. And so A is that remnant, B is the vaginal septum, and C is a dual vagina. And they make these measurements with their ureteral catheters. And so they further go on to discuss, are these remnants incidental or are they clinical? 4 different papers that have described the clinical reflection of these changes. Things such as difficult or poor breeding, infertility, and dystocia have been described, along with urinary incontinence, vaginal pooling, chronic recurrent UTIs and vaginitis, and dysuria. At this time, there wasn't any reported breed or genetic predispositions, and ultimately the prevalence is unknown due to the commonality of early spaying, with the idea that maybe some of these dogs that would have been clinical for more of the breeding related complications, we just never catch them. But we do know that they're reported in up to 93% of dogs with ectopic ureters. So it seems like if they have one abnormality, they're likely to have another. And so again, the purpose of this was really just to describe the therapeutic option and the outcomes, with the hypothesis that it would be safe, effective, and permanent for resolution of these remnants. And so this was a study done out of Penn and AMC. They included females with these remnants, septums, or dual vaginas, all treated endoscopically. They excluded those with no vaginal openings if the bands could be digitally torn and if they had short follow-up. All of these dogs had a minimum database and culture prior, and then they collected signalment, continence history, the presence of UTIs or vaginitis, physical examinations, including vaginal exams, and then the type of malformation and concurrent abnormalities. For the procedure itself, all of these dogs were done in dorsal recumbency, and they went retrograde with a rigid cystoscope. They did do their urethrocytoscopy first and corrected ectopic ureters if present, but then noted specifically urethral length, the presence of an interpelvic bladder, and then the classification as well as, or the classification based off of ureteral catheter measurements. They used either diodes or Honum YAGs for ablation, and then they went caudal to cranial using a ureteral catheter as a guide and until the vaginal vault was a single tube. Pretty standard for intra and post-op, so pain meds, antibiotics, topical bupivacaine, sent these dogs home on NSAIDs or tramadol, and then about a week's worth of Clavamox. Rechecked cultures at 2 to 4 weeks after antibiotics, and then at 8 weeks, 3 months, 6 months, and Q6 thereafter. And then a small number of these dogs had rechecked cystoscopies at 6 to 8 weeks following their procedure for another study that they were doing. The owners were also provided with a questionnaire that evaluated the continence of these dogs, presence of recurrent UTIs, quality of life, and then other concurrent illnesses. Worth noting, the continence score that they used is a 1 to 10 scoring system, and they took these measurements or these questionnaire measurements at 1 week, 6 to 8 weeks, and then at last follow-up for all of these dogs. 1 are the dogs that are constantly leaking, 5 is moderately, and then 10 are the perfectly continent dogs. They use Shapiro-Wilk for normality. Medians and IQRs were presented for all continuous variables, and then frequencies and percentages for all categoricals. Use Wilcoxon for comparison of the continence scores before and after ablation, and then McNamara for frequency of UTIs pre and post. And so they included about 36 dogs in the study, 18 which were spayed at the time of the procedure, and then the remaining 18 had been spayed by the time the study was completed. Interestingly, only about 4 of these were mixed breed dogs, and a large majority were purebreds, with golden retrievers, Wheatons, and labs accounting for most. There's about a 17 kilogram median weight at evaluation, and most of these dogs were about a year when the procedure was performed. A large majority of these dogs, so 72% of them, were incontinent. Of these, 2 of these also had UTIs, and 8 of them had a combination. For a quarter of them, this incontinence or these changes were noted since adoption. A smaller amount they didn't know. About 13 of them had hooded vulvas, 28 of them had historic UTIs, and then kind of a smattering of these ultrasound changes where 4 of them were diagnosed with ectopic ureters on ultrasound. Worth noting that 5 of them had historic surgical ectopic ureter treatment. And so they did find that these paramesonephric remnants were most common, so accounted for a little bit over half. Vaginal septums were next, and then followed by dual vaginas. They addressed these endoscopically, or they ablated them via diode for a large majority, with a procedure time ranging from 30 to 120 minutes. Kind of as reported previously, a large majority also had concurrent urogenital anomalies, so almost 90%. 30 of them, so 83%, had ectopic ureters, 5 of which were previously corrected, and then almost half had short urethras, 36% had pelvic bladders, and then the remainder had either various other unrelated changes or changes related to the ectopic ureters. And so they did find only about 6 complications, so 5 just being mild dysuria, all of which resolved within 24 hours. They do remark that 4 out of those 5 had concurrent ectopic ureter ablations, which may have been the cause. 1 did have a vaginal perforation, I think because of dislodgement of their guiding catheter, but really there was no external effects, and it had healed at 8 weeks later. Another helpful thing that they did here for that other study, so 18 of these animals did have recheck endoscopies 6 weeks later. And all of them had fully healed sites of ablation with a fully open vaginal lumen. And so this is a picture of one of those that was ablated previously. And ultimately, they noted a significant improvement in continence scores and improvements in UTIs for all. So probably a more significant improvement in continence scores based off of a presentation continence score of 3, ending at between 9 and 10 at the last follow-up. There was an improvement in the UTIs, as you can see here, from 32, so 87% to 46%, but still about half of them did develop UTIs. Of note, 1 dog actually did die of pyelonephritis about 4 months later, but all of them were alive, and about a 34 median month follow-up time. And so as far as their discussion goes, they talk about how vaginoscopy was 100% effective for the diagnosis of these anomalies, and the remnants were by far and away most common. It does seem to be long-term effective with low morbidity. But then they also explain how the definitions were previously kind of variable, so this is helpful to have a more standard way of explaining them. And then, as we talked about earlier, vaginal stenosis was not identified on any of these patients. But they do then go on to remark where what was previously described as a sequelae vaginal stenosis, but theories that these remnants could cause urine pooling, and then further go on to describe the idea that they may cause tethering of the urethral meatus, so causing that urethra to be dilated. They also mention that anatomic defects may predispose to UTIs even after ablation of these anomalies, given the still fairly high prevalence of UTIs following ablation. And they also remark that there is a high likelihood of fixation of concurrent abnormalities contributed to improved incontinence or continence. But what I wanted to specifically note is the fact that 6 of these dogs did have remnants alone, and all 6 of those were improved following ablation. So 4 of them were incontinent, 2 of them had recurrent UTIs, but again, all of them improved. Limitations, of course, were small sample size, the presence of multiple anomalies and variable procedures, but I do think this makes a nice and probably first case for addressing the remnants if present. But this is where I wanted to ask the second poll to the group as to whether or not vaginal remnants are routinely ablated at your hospital, and if so, what recumbency, because we tend to do ours in lateral.
Open for 5 more seconds. Those are the results.
Great, and so this is kind of, in a way, what I was hoping for in that we started doing ours in lateral just because we have seen a little bit more difficulty or have had a little bit more difficulty getting a great view of either side of the vaginal opening in dorsal. I don't know, did anyone want to chime in and explain why they do them in dorsal more commonly?
I used to do them actually sternal when I first started scoping, and I thought everything just opened up and I had so much better visualization when they were in dorsal. Personally, I do everybody in dorsal. I do my contrast studies in lateral, but otherwise I'm always doing cystoscopy on their back. It just seems easier. I've never had a problem where I've run out of ability to visualize things personally.
Okay, awesome, thank you. All right, with that, we'll move on, and I'll talk a little bit more why we think lateral might be easier. And so for our first case, we have Sophie, who's an 8-month-old female intact golden, who presented to us for urinary incontinence since adoption. It was noted as constant dribbling, so a continence score of 1, seemingly worse when she was sleeping and resting, but she was able to produce a normal urine stream in small amounts when she postured. She did have no response to escalated proin and had a previous urine culture that was negative. On presentation to us, her physical exam was pretty unremarkable. As you can see, she had a little bit of salivary staining around her muzzle, probably because of her constant vulvar grooming. She did have associated perivulvar dermatitis and some urine scald, but did not have an overtly hooded vulva, and the rest of her physical exam was pretty unremarkable. Similarly, her minimum database was normal. She could concentrate, urine culture negative, but ultimately the ultrasound was somewhat unrewarding in that her bladder was pretty empty even after allowing some fluids, so they couldn't necessarily evaluate the presence of ectopic ureters. So we ended up taking this dog to scope just because of her degree of incontinence and, of course, the concern for ectopic ureters given her breed. And while we didn't find any evidence of ectopia, we did find this rather strange looking vestibule urethral opening and vaginal opening. So she did have a what would be determined as a vaginal remnant based off of the size of it, as well as these kind of what we suspect to be lymphoid follicles within the urethral opening. We, of note, then ablated her vaginal, or the vestibulovaginal septal remnant, and almost immediately, and then especially upon reevaluation within her vestibule with the same amount of fluid insufflation, noted that not only did her vaginal opening closed more, but so did her urethral opening. I think at this point we were all kind of questioning, is this actually going to do anything? Is she more of a USMI dog? But ultimately it did. And so on the left here, we just kind of have a review of what we found on the cystourethropy. But as far as her response goes, she actually improved within about 24 hours. But at 2 weeks, she was completely continent. Similar at 4 weeks. At 8 weeks, she did develop a recurrence of dribbling with a recurrent UTI that ultimately resolved after 7 days of Clavulux, and so did her dribbling. And so I wanted to talk about this one because it is a more convincing case of what we would call band-related incontinence. And so it's also notable that the development of a post-ablation UTI is kind of consistent with that ELA study. But the theory, again, is that the band kind of tethered open the urethra, resulting in a type of urethral incompetence. I suppose an alternative theory would be that the band predisposed to vaginitis, especially given the lymphoid follicles exacerbating underlying incontinence. But again, she did not seem to be clinical for vaginitis at the time of ablation, and that's all that we did, which fixed it. So I did want to ask the group here for our next poll if there's been suspicion of these VVSRs as the primary cause of incontinence at your respective hospitals.
Five-second warning to close the poll. Results.
Awesome, thank you. So I think that seems to be the general consensus for at least a lot of the studies. And I think that also is a reflection of the fact that, again, so many of these animals probably have concurrent disease, which we'll get into in the future. But I wanted to talk a bit more about another case that kind of goes along those same reins. And so this is Scout, who's a 6-month-old female intact soft-coated Wheaten Terrier, who also presented to us for urinary incontinence that was actually progressive. So initially only at rest, but then progressed to being more constant, so a continence score of 1. She did groom her vulva pretty excessively and had multiple presumptive UTIs based on urinalysis. I remember they probably couldn't get a cysto sample because her bladder was always so small, but they did trial multiple courses of antibiotics, each of which would result in a partial improvement in her incontinence, but never complete resolution. She similarly was able to posture and urinate a normal stream. On presentation to us, pretty similarly unremarkable physical exam. So she did not have a hooded vulva, but did have significant urine scald and that kind of hyperkeratotic inguinal skin. CBC and chemistry were similarly unremarkable. She had a little bit of pyuria on her UA, but I think her urine culture ended up coming back negative as well. But most notable is that on her focal urinary ultrasound, there was suspicion of unilateral, if not bilateral, ureteral ectopia. Again, difficult to completely determine because of the fact that her bladder was caudally positioned and it was not full, but they remarked on a partially intrapelvic urinary bladder as well. So we ended up taking her to scope the next day, and I'll have to orient you because these are some weird images. So this is in the vestibule, and so she is laying in lateral here. On our right is our urethral opening, and then here's where we suspect the vaginal opening should be, possibly connected by these two small little openings. When we moved her around, it did become a little bit more apparent that these probably weren't blind-ended openings and maybe were connected with the vaginal vault, but still pretty difficult to tell. I think also worth noting is that, at least in this view, you can kind of see into the urethra here, and it's very clear that the urethra is very dilated. Not only that, but you can see this kind of tense band of tissue. And so when we evaluate that further, that is this band here, and I apologize, not a great image either, but this is what appeared to be a left-sided ectopic ureter. Interestingly, depending on the amount of fluid that was insufflated, the neck of the bladder actually would close down, so it almost appeared like two big pouches. But regardless, this confirmation did make us a little bit concerned that this ectopic ureter was coursing away from the bladder, so potentially extramural, which is why we then took her to CT for a contrast study. And so we do see pretty clear ectopia with that same urethral dilation. It did appear somewhat extramural on this image, but then especially so on this view. And so they did call it a left ectopic ureter, likely extramural. But then notably, they also remark that there was no evidence of contrast media that was uptook into the vagina. And so ultimately, we woke her up with a plan for more of a hybrid, minimally invasive and surgical intervention. And so we had planned to do the endoscopic laser ablation of the septum, followed by surgical fixation of her extramural ectopic ureter and or vaginal perforation if we got too aggressive, as well as a spay, and then kind of manage her symptomatically throughout. She did end up going through her first heat cycle about 5 months later, returned for her appointment 6 months later. Similar PE. They had actually managed her urine scald pretty nicely, and then her pre-op labs were also normal. But when we scoped her, also some really cool images here. So this is the same location, so we're within the vestibule, but we can still see a very open distal urethra, and then these two kind of holes where we think the vaginal opening should be. Again, with different views, you can see that it does seem to be more continuous with the vaginal vault. But I really like this image on the left here because you can actually look back into the dilated urethra and see the ectopic ureter, which again seems to be coursing more away from the urethra itself. So we proceeded with our plan to try and ablate this tissue, and so we have this little hook cautery device that we like to use. We passed a red rubber into that lateral opening, and then we like to use this specific tool because it kind of allows us to brand across the tissue. And so as we do that and release some of that tension, we can see that the openings start becoming bigger. And so we just kind of go at it in layers. And ultimately, we were able to completely ablate it. It appeared to be more of a vaginal septum, given how far back it went, but not all the way to the cervix. And then here's what it looked like after the fact. But I think also worth noting is that, again, this is what it looked like beforehand. This is what it looked like after. And while certainly not normal, there is still a fairly subjective narrowing or decrease in size of the urethral opening. And that's actually further reflected by the fact that when we went back into her urethra, the ectopic ureter was a little bit less convincing as an extramural. And so we went ahead and started ablating it, and it did turn out to be intramural. And this is in action, not necessarily in product, but we were able to ablate it into the trigone of the bladder. And so this was one of the first very clear cases, at least that I had done, where following ablation of the band, the urethral conformation changed enough that we had really a completely different evaluation of the anatomy in the ectopic ureter. And so, again, this is what we found on her scope, but her response was pretty significant. So within 24 hours, she had improved. At 2 weeks, she exhibited that kind of fluctuant change where she was completely continent. At 4 and 8 weeks, she had a mild recurrence, primarily at rest, but she has since been completely continent on Q12 Proin. And I wanted to also bring up this study that further outlines the prevalence of these anatomic urogenital anomalies in Wheaten Terriers. In this specific study, they did find an increased hospital prevalence of urinary incontinence compared to other breeds with a lot of these anomalies, so ectopic ureter, shortened urethras, remnants, and bifid vaginas. And so this is going back to the question about lateral versus dorsal. This is one of the cases that caused us to start doing these dogs in lateral to ablate the bands if present, and then switch to dorsal with the idea that we could maybe more accurately evaluate for ectopic ureters replacement of them, with a similar theory that, especially with the thicker malformations, maybe tethering their urethra into a location that may change the conformation that we visualize. And so this is where I wanted to ask the group the next question. If you all have seen conformational changes following ablation of vaginal remnants and or other anatomic abnormalities at your hospital.
Second warning.
Awesome. So it looks like a little bit over half of people have seen this, and this is kind of what I was hoping, not only because obviously we have seen it, but it's really not mentioned anywhere in the literature. And so I think it's helpful to know that, especially when we have more confusing cases that we are evaluating in different lateralities and especially via cystoscopy. And so moving
Tanner?
on, yeah, go ahead.
So just there were a couple of comments in the chat that I've been watching, and I wanted to ask too. are you guys doing fluoro during your cystoscopy? Marilyn notes that in her experience, CT over diagnoses extramural ectopic ureters, and that would be my opinion as well too. And we would have wired and then catheterized that and done a fluorocystourethrogram and ureterogram, and I feel like that gives us a pretty high level of confidence in whether they're intramural or extramural. And I just wasn't sure if you guys were doing fluoroscopy as part of your evaluation or not.
Yeah, that's a really good question and something that we talk a lot about. So unfortunately at NC State, we're not set up to do fluoroscopy quite as easily. It's a little more of a logistical challenge. I would start by saying we totally agree with Dr. Dunn that CTs and even ultrasound tend to overestimate extramural, whereas we tend to rarely see them. But yeah, so we more commonly we'll just make that call based off of the endoscopic evaluation and don't often do fluoroscopy is kind of the short answer to the question. I don't know if Dr. Baden wanted to chime in.
Yeah, I did, as always. What everything Tanner said is correct, but I think because we've never we've had to rely on what we see more than with our eyes with the scope more than fluoroscopy. I think we have just a different feel of getting to it, and it became a political thing as to whether we got fluoroscopy or not, and we just didn't. And it became really hard, very expensive for us to add fluoroscopy on, so we've kind of gone down this path. But I would say that I also think that in our hands at our institution, when we do contrast studies of in any method, we overestimate the diagnosis of extramural. So many times I would rather try to start lasering it or ablating it and kind of see what happens to the anatomy change and whether we see the ureter diet off, and most of them end up being intramural. And I would still advocate that we don't need to do fluoroscopy in the middle of most of these, although in some of them.
In our hospital, if we were to do a CT, that would be dramatically more expensive than fluoro. Fluoro adds about maybe $200 onto the cost of our cystoscopy. So it's certainly cheaper, and we're already there. You know, we would do this in our OR that has a C-arm set up, rather than if I'm just doing a regular diagnostic cystoscopy, I'm going to do it in a different suite. I don't know if Tracy, if you have a microphone available, because you shared some information on the chat, which is really interesting. I don't know if you have a mic that you would be willing to just kind of share what you said on your chat.
Yeah, I did this was when I was at the University of Edinburgh. We did a study where we retrospect, I think it was like 20 or 30 dogs that had IVU CTs followed by cystoscopy and laser ablation, or plus minus laser ablation. So it was basically just every dog that we'd done CT, IVUs, and cystoscopy on. If I remember right, I think like 60 to 70% of them were ectopic. And so I did a study with a radiologist where we both retrospectively reviewed all those cases. He classified them as intra versus extra on the CT. And then I reviewed the cystoscopy videos because we recorded the entire cystoscopy as just a matter of course. So I reviewed those also after the fact. We were both blinded to the result. And there were, I don't know, at least 12 cases, maybe not as many, certainly more than 8, where they were classified in the CT as extramural, and I laser ablated them. So I know with 100% certainty that they were intramural. So that, I think that's just interesting to me that, and I also agree with Shelley that I think even a fluoro study can be a little bit misleading for what's intra versus extra. So I think I agree with all the comments that CT overstates it. And that data wasn't ever published, mostly because the radiologist wasn't that keen on having a paper be out that CT wasn't very good to diagnose ectopic ureters.
Thanks so much for sharing that. And then there was also a question for those people who don't have fluoroscopy. Aria was asking, how are people checking to make sure there's no leakage after lasering without doing a contrast study?
That's a good question. I guess I can say at least at NC State, it's not something that we are commonly checking for, but I think if there's suspicion that the bladder is not filling like we would want, so if we're not getting kind of that pushback from the fluid insufflation, then we'll just grab our kind of bedside ultrasound and check for free fluid. I don't know if others had different thoughts.
I've had a small tear because I was being a bit too aggressive with how far back I was taking the ectopic ureter into the trigone, and there was a little bit of contrast leakage when the bladder was really full. But it maintained its size, like it didn't shrink down. I don't think without contrast there would have been zero chance I could have detected it. And because it was small enough and the bladder was maintaining itself and we weren't getting constant leakage, we actually didn't do anything different. We just told, made sure the owners were aware and there was no complications associated with it. But it wasn't as if all of a sudden all of our saline that we were using to insufflate was just leaking into the abdomen. But the contrast study did detect a leak that we wouldn't have known otherwise for my one time that I've seen that happen.
Yeah, I've had a couple cases that they started intra and then went extra. So at some point in the transition phase to extra, like maybe I was a little bit wary of, is the tissue a little bit thicker? Is it starting to dissect away? And in those couple of cases, I didn't actually do a contrast study. I just left a UCath in them overnight and they were totally fine. So I don't know with 100% certainty whether or not they had leaks. But just having the UCAT, I mean, if there was something, it wasn't big enough to be leaking saline or anything out, obviously, and just putting the UCAT in overnight was enough.
Yeah.
And Marilyn also brought up a comment that you can use fluoro to define where you start, where you end, to make sure that in some of these patients, especially if they do have intrapelvic bladders, sometimes their bladder looks almost like the urethra as well, continuously. So being able to have fluoroscopy to document, hey, here's where it started in the urethra, here's where we finished, or I can go a little bit further. I've also found that to be helpful, but I guess I might be a bit spoiled by having fluoroscopy being cost effective and available when I'm doing these procedures.
Yeah, I think you learn to look for different things. So I feel very confident that we can know where to properly end our ablation without it. It's just it's our handicap, that what we've learned with. But I know that Tanner has a whole lot of more information that he wants to get to. So great discussion, but let's try to see if we can do a little bit more.
Yeah, awesome discussion. But we will move on to the urethral component. And so this is, again, not an exhaustive list, but it's a number of what I considered more urethra-specific papers, though ultimately I think my takeaway was that there's kind of minimal definitive conclusions, and we won't go through each one, but I think just from a brief overview from this very first one, we find that urethral necks are indeed longer after bladder distension, unknown if that correlates with clinical signs. In the second one, we find that the bladder neck is more caudal and the urethra is shorter in spayed dogs when compared to intact. Still unclear if there's a relationship with incontinence. 3, there's really no relationship between this urovesicular angle and incontinence in intact female dogs. This study looked at this specifically due to the known role that the posterior uretrovesicular angle in women plays in stress incontinence. Here we find that intrapelvic bladders and urethral flexures can occur, but they can also occur in normal dogs. And so all of which just kind of going through this idea that who knows what abnormalities we can diagnose on imaging actually mean. In this nice review from 2010, it does further kind of outline some of the urodynamic principles and neurologic and hormonal influences, but it also had a lot of really cool studies that it cited. And I actually wanted to talk more about this urethral mobility and urinary incontinence paper, given the suspicion that these vaginal remnants may affect urethral conformation. And so this paper ultimately starts by defining SUI, or stress urinary incontinence, as a combination of pathologies affecting actually one or more of the bladder, neck, urethra, and pelvic floor muscles. And it's actually generally believed that the SUI occurs if the urethral support is defective, so due to an impairment of pressure transmission with increased abdominal pressure. And they postulate that this altered pressure transmission actually then results in the failure of the bladder neck or urethral sphincter to know when to close, resulting in urine leakage. And so in this study, they did find that worsened symptoms of incontinence were found to be associated with a general increase in urethral mobility or urethral hypermobility. And this study is important because it was previously thought that it was just the proximal urethra or bladder neck urethra that was the primary issue. So going back to that angular issue, but this actually argues that the mid and possibly distal urethral conformation and mobility is really important as well. And again, I bring this up because of the continued suspicion that changes within the urethra throughout, secondary to vestibulovaginal abnormalities, may be a bigger player. And I think this case kind of outlines that a little bit. So this is Bailey, who's a 6-month-old female intact golden who presents to us for plaqueuria since adoption, and then I think one suspected episode of maybe puppy vaginitis. The plaqueuria was not responsive to antibiotics. She actually did not have overt urinary incontinence. And her urine cultures were previously negative. However, she did have a litter mate with ectopic ureters, and her mother had a hooded vulva. On physical exam to us, pretty unremarkable. She was not leaking, did not have a hooded vulva, otherwise looks pretty good. Similarly, her labs were normal as well. On cystoscopy, we did not find evidence of ureteral ectopia. We did think that her bladder could be partially intrapelvic, but what we found is kind of an abnormal or asymmetric shape to her urethra and her vaginal opening. So if you can see on my pointer here, we found that, or thought that there was this kind of tethered portion of tissue from this lateral aspect of the urethral opening going to the opposite aspect of the vaginal opening. And you can see like all of this tissue right here looks really white and really tight. And so because of the availability of that hook cautery device, we decided to just start ablating away or branding away at what looked to be the tighter tissue. So we really took away this corner right here. And even immediately you can see that all of the more lateral tissue is under less tension. And then after we went in and reevaluated the urethra, bladder, and came back and insufflated the same amount of tissue, you can see that there's even more urethral closing. Again, this could have been done. This could be due to like changes in the way that she was positioned or the amount of fluid, but we thought it was pretty notable. I think at this point we were all questioning whether or not it would actually have an effect, but it turns out it really did. And so this is a review of her scope findings, but ultimately within 24 hours, she did not have plaqueuria or leaking. Now, she hadn't exhibited that in hospital previously, but the owner previously described this dog as needing to be let out every 3 to 4 hours, or else she would urinate within the house, not leak. This was not present at 1 and 4 weeks after the procedure. And then I actually checked in with her about 10 days ago, and she was still completely normal. And so again, the thought here is that this band of tissue, while actually not incredibly apparent or within the middle of the lumen at this point, was potentially causing impaired urethral pressure transmission, similar to the hypermobile urethra in humans, but maybe to an opposite effect, therefore resulting in maybe earlier and more significant pressure transmission at relatively lower bladder volumes, and then causing the dog to feel the urge to urinate more frequently. Again, this is all just a suspicion, but because that was the only thing that we fixed and everything went away, I think it builds a nice case. But I did also want to poll the crowd here and just see if anyone else has seen these asymmetric urethras or redundant vestibular tissues, and if so, if they've been addressed endoscopically.
Second warning.
Great. So it looks like a large amount of people either haven't seen it or they have tried to ablate it. And again, this is something that we've been noticing a little bit more recently. And so for sake of time, I didn't include all of the cases, but there's at least 3 right off the bat that I can think of where they really had no other anatomic anomalies that we found on cystoscopy besides just kind of changes within the vestibule. So these tightened bands of tissues that we believe cause a tethering effect, and that once we ablate them really result in an active change in the urogenital anatomy. And so we'll kind of continue to collect those cases, but just something that I think is worth noting because of this idea of urethral mobility and the effect that any sort of change or excessive tissue in this area may have on the urethra. But of course, it's difficult to kind of break up the urethra and the bladder and really any sort of any sort of part of the lower urinary tract. And so I did my best to kind of section off some of the more bladder-associated papers. And ultimately, I think this has been discussed in the ASVNU listserv before about pelvic bladders, but it's kind of defined as a positive contrast cystogram in which the neck or a portion of the body of the bladder is positioned caudal to the pubic bone within the pelvic canal, creating that kind of pear-shaped. And so these first few studies really just explain how to document this, but also that these pelvic bladders are not always associated with incontinence. And then within this same kind of volume of acquired urinary incontinence, this last study is a nice one that summarizes the treatments for USMI, but ultimately outlines and concludes the fact that things like colposuspension, urethropexy, submucosal collagen, and artificial urethral sphincters have various variable success rates for kind of unknown reasons as to why one will respond and one will. And so I wanted to talk a little bit more about this last paper because despite wanting to fix everything minimally invasively, sometimes we can't, and it seems like the urethra may not be the primary problem or the vestibulovaginal vaults. And so this is a paper that really just essentially describes the surgical techniques to address urethral incompetence and specifically outlines a combination with the thought that it may increase overall success when compared to singular interventions, which ultimately it does, but I think it creates this nice case or a nice idea of the fact that different parts of the lower urinary tract may actually need to be addressed specifically for us to get control of urinary incontinence. And so kind of in contrast to this idea, or with this idea, excuse me, is our next case, which is Mermaid, a 3-year-old female spayed boxer. It's actually kind of sad she was named Mermaid because when she was found, she was constantly wet from leaking. But she had severe constant urinary incontinence with urine scald. She again was able to posture, but her bladder was never full enough to produce more than a few teaspoons of urine. No response to incontinence medications and dose escalations. There was a mention of a historic UTI, but her recent urine culture was negative. Similarly, unremarkable physical exam, no vulvar hooding. Her labs were also unremarkable, and then ultrasound and cystoscopy, kind of surprisingly, mostly based off of her degree of incontinence, did not reveal any evidence of ectopia and also normal kidneys. However, we did find this, and I'm sorry this is not a video and kind of another poor still image, but bear with me here. So on the right here is actually a very large urethral opening, distal urethral opening. And this little hole right here is what we suspected to be what was left of the vaginal opening. We actually were able to pass a ureteral catheter through that, and kind of using the same technique as that Wheaton Terrier, we just kind of branded along the tissue that we suspected would be where the vaginal opening would be, and ultimately, and luckily it was. So we kind of made up an opening that was the same diameter as the urethral opening, with the thoughts that, hey, maybe this is one where it had true vaginal stenosis and maybe it was affecting the rest of the lower urinary tract. Unfortunately, that was not the case. So within 24 hours, she was still leaking. At 2 weeks, the owners had mentioned maybe partial improvement. So it was now worse primarily when she was active. But even at 4 weeks, she was still severely incontinent, restarted some of those incontinence medications to which she showed no response. And then she returned to soft tissue surgery about 4 months later. And this time we did do fluoroscopy. And they did find significant dilation of her urethra and then poor pelvic or poor bladder filling. I think like less than 5 mils per kg of fluid would result in leakage out. I think notably her distal urethra did seem to at least close based off of this view. This is in contrast to what we thought we saw on her cystoscopy. But ultimately they took her to surgery and had to scope her at the same time. And so what I think is worth noting is that here on the left side, her vaginal opening and her urethral opening look somewhat more normal. But this image here on the right is actually sitting with a regiocystoscope in the very distal urethra. And so you can see that all of this tissue here is dilated urethra. And back here, this kind of second circular area is actually the bladder neck. And I think this is one of the ureteral openings. And so significant urethral dilation. This light is because she was opened up at the time in surgery. But they ended up performing a urethral plication, and this is what the urethra looked like after the fact. This is a case where she did respond very well to it. So within 24 hours, she was actually markedly improved. And then at 2 weeks and 4 weeks, she was completely continent. 4 weeks, she developed, I think, 2 or 3 nights of a little bit of leakage overnight. But by the time the owner went to pick up the Pro-In, it had already resolved. And so I did want to pull the crowd here to see if you guys had any sort of sense as to what type of surgical technique is typically utilized for bladder fixation, especially when the urethra isn't being evaluated specifically. I recognize we may not know the answer to that, but thought I'd be curious to see.
Morning.
Yeah, I figured the last answer would take the win for this one. But yeah, so ultimately, at least at NC State, it tends to be a little bit of surgeon discretion, and then also what we are finding on our cystoscopy. So whether the degree of how pelvic the bladder is determines whether or not we pexy the bladder, or if they see that the urethra is truly very dilated, if they do something like a urethral plication in this case. But I think ultimately it's been really difficult to get a sense of what is the best way to do it, especially when we're not doing a combination of procedures. And so that's kind of where I wanted to lead into this idea of the more dynamic changes. And so this is just a culmination of some of the papers that I think best represent the fact that there is probably a significant interrelation between all of these abnormalities in these parts of the urogenital tract and lower urinary system that can result in dysuria or incontinence. These last two papers are really cool and a little bit more recent. So this first one is a dog that actually had urethral obstruction secondary to caudal bladder displacement, trigonal invagination, and this really great example of urethral kinking. This is a dog where they did perform cystopexy that completely resolved all of the findings here and the dysuria. Similarly, in this next study, intermittent urethral obstruction secondary to caudal sliding of a pelvic bladder. These are all 3 Yorkies. Only one of them was a female, which is this one. And then similarly, they did a left-sided cystopexy and right-sided uteropexy, which completely resolved the changes. So this idea that probably the bladder is the primary problem, but it's ultimately affecting the urethra and the rest of the urinary tract to create these signs as well. And that's where I wanted to go into this case. Hopefully I can get through it with the amount of time we have left. But some of you may be familiar with it because we did talk about her on the ASVNU listserv. But she's a 4-year-old female spayed Dobie that came to us for incontinence. She was actually first noted to be incontinent at 5 months of age, resolved with Proin, went away, but then she had a litter of puppies, I think the summer before I saw her, spayed a few months later, and then became incontinent at rest shortly thereafter. No response to medications, normal voiding otherwise, but overall it was a pretty fluctuant incontinence patterns in that sometimes she would spot some days, other times she would be constantly dribbling. Her labs were pretty unremarkable, ultrasound similarly unremarkable, but we did go ahead and scope her with really the intent to do some collagen injections. But we found a pretty significant vaginal septum. So this is an image of her vaginal opening with what is the redundant tissue right here. We ended up ablating it, and as you can see, the urethra looked pretty normal here, and it did close nicely. This is the degree or the length extending cranially, so again, determined to be a vaginal septum. We did ultimately proceed with the collagen injections too, just due to the suspicion for primary USMI. So here's a picture of that. It went really well. But unfortunately, she didn't respond as nicely as we had hoped. So she had continued fluctuant incontinence, and the owner actually thought that she had worsened within the couple of weeks following to where it was severe and constant leaking 2 to 3 times per week. And so interestingly, when we quizzed the owner a little bit more, it actually sounded like the most amount of urine that she would produce was when she was rising or running, so small amounts of urine would come out. We tried medications again. We even tried this electrostimulation device, which she clearly tolerated very well, but it did not result in any sort of positive effect. Similarly, trialed a low sodium diet, but ultimately did not work. So she did come back kind of with the same idea as Mermaid, starting with a fluoroscopy, which actually did diagnose some degree of a pelvic bladder, but also this urethral kinking that notably was dynamic. So depending on where her legs were positioned, so this is when her legs were pulled forward, if they were pulled a little bit further backwards, then her urethra would completely straighten out. So they called it ventral deviation and focal dilation of the proximal urethra, and then partially intrapelvic bladder, but I think kind of consistent with that case that I just mentioned a couple minutes ago. Ultimately, she went to surgery for a cystopexy and colposuspension, and she did respond pretty well to it. So within 2 weeks, she had significant improvement, but continued to leak small amounts at rest. We restarted Proin, and she was drier than she was wet, but she returned about 6 months later due to continued spotting at rest. We did a contrast cystogram. Her bladder was still in an appropriate place, but we did diagnose the fact that she was retaining a little bit of, or about 2 mils per kg of urine following voiding. We did trial her on Botanicol, and believe it or not, within a couple of weeks, she was completely continent and continues to be. And so the theory here was that this dynamic urethral kinking, probably due to an intrapelvic bladder and then probable overflow incontinence, was the cause of her symptoms. But once we addressed the urethral kinking, overflow incontinence manifested because we took away what was kind of previously preventing that temporal incontinence, making this a very kind of mixed and dynamic case of urinary incontinence, which apparently is a struggle in human medicine too. And kind of what I wanted to leave everyone with is this paper that I found that I think best describes it, this idea of mixed incontinence. And so it's described as or caused by disturbances in storage and emptying, where urethral sphincter dysfunction and bladder dysfunction probably coexist. They have these 4 pathophysiological theories. I think the number 2 is probably most easily attributable to veterinary medicine, with an intrinsic sphincter deficiency, but ultimately changes in kind of the anatomy and the relationship between the different parts of the lower urinary tract and the urogenital tract could contribute to this type of incontinence. And they ultimately remark that an effective single treatment may well not exist, and treating one type of incontinence at present could result in worsening in the other. And I think in conclusion, while again not directly translatable to vet med, we imagine that there are probably a number of these cases of mixed urinary incontinence in female dogs, and I guess probably male dogs too, but that these cases may be due to any combination of not only the common causes of incontinence that we see, like USMI and ectopic ureters, but maybe even the less typical ones, like the ones that we just discussed. So with that, I will take any questions and kind of open the floor to discussion. I think I saw the chat was going off a little bit. So I'm seeing a question, what is the treatment of dual vagina, laser ablation? Yeah, so that is described, at least in that endoscopic laser ablation study. They did treat a small amount of those with laser ablation. What else do we have? And then, yeah, the comment about evaluation for kinked urethra with all fluoros. I totally agree, and that's kind of what one of my big takeaways was from reviewing this literature, and then of course that last study, is that I think not only dynamic changes are easily missed, but it took a lot of questioning of this owner to finally get this idea that actually her incontinence had worsened when she was getting up or when she was moving or during these very temporal associations. So I think it's very reasonable to add that to fluoroscopy.
All right, any other questions or comments? Tanner, this was a really fantastic presentation. This was incredibly thorough literature review, and having cases to show some of these topics that are still confusing, I think, even amongst us. That is, it was a lot of work, and we really appreciated. That was a really wonderful presentation. Really, thank you for putting it all together, and thanks to Shelley for helping out with it as well too. I'll go ahead and bring today's session to a close. We will have this recording posted on YouTube, so it'll be available. It can be linked from our ASVNU website, and further announcements for the next journal club will be made through the ASVNU listserv as well as our website. So if you're here just through my posts on ACVM, maybe consider joining ASVNU, or keep an eye on the website for future meetings. Otherwise, thank you guys so much. Really appreciate everyone attending. We had a great group today, lots of really terrific discussions, and I really had a wonderful time. So thanks again, Tanner. Amazing presentation. Really appreciate all the hard work you put into it.
Yeah, thanks everyone.
All right, well, hope everyone has a wonderful rest of your day and your weekend, and we'll see you again soon.